We welcome you to this new podcast where we have a lot of guests and we are all going to talk about how the growth factor can basically help the early stage of osteoarthritis patients with their pain. So we have with us three eminent orthopedic surgeons, Dr. Chirag Borana, Dr. Subhash Jangid, and Dr. Rajesh Gandhi, who will be talking to us. And we have with us Dr. Salim Patel, who's my very good friend and the chief medical advisor of Vocard Hospitals Private Limited. So with this, I hand over to Dr. Salim Patel to discuss today's topic, that is Ossinext.
Yeah, thanks a lot, Neeraj. Good evening to all our viewers and good evening to our esteemed panelists who are available today. And on this very new podcast, which we have just recently started, as rightly said, orthobiologics, as everybody knows, is one of the most in vogue therapy right now. In the last 10 years, it's been growing to leaps and bounds. And the very fact, the evidence about orthobiologics has been through the various symposium in various conferences where orthobiologics is now getting you can say, a primary spot of discussion with many speakers and many orthopedic surgeons getting involved in this type of therapy and sharing their success results and also giving testimonies of their patients how good this therapy is at early stages of various orthopedic indications. So just to brief about what Ossinext was, how we all started about it. So this is just a therapy like any orthobiologics where actually we are treating various injuries, chronic conditions which are affecting the muscles, bones, and the joints, and even soft tissues like ligament, tendons, and cartilages. So in orthobiologics, we are using the cells from the patient's own body, which is autologous, or even sometimes through the donor, which is allogenic, to improve recovery after any orthopedic indication which develops either because of an injury or a minimum damage to a particular bone cell or a bone tissue, leading to degenerative conditions. So it has always been one of the most prominent indications where orthobiologics have started developing its own curve and own, you can say the forte was coming up over a period of time. So most commonly the cells used in regenerative medicine or orthobiologics was like your adipose tissue, bone marrow, then your blood plasma, which includes obviously a PRP, which is a gold standard treatment, which was there since quite along in the early 90s. It started and gained traction over a period of time. Doctors were doing injecting either into the indications like, for example, in arthritis, were injecting in the joints, ligament, tendons, or cartilages, where all the patients were experiencing pain. And once injected, these cells used to reduce the inflammation, which helps in minimizing the pain, promotes healing, and obviously improves the joint function. So PRP was one of the modalities. So apart from all the various types of orthobiologics, today we are discussing more on growth factors. So as you know, growth factors are a component of your platelets. So PRP, which was the initial therapy in this type of a treatment of blood plasma, it is still a very good treatment, does pretty well, but had its own challenges where actually the doctors were a little whimsical about using this therapy over a period of time. So for example, if I enlist the challenges, the most common one was no standardization of a protocol. Sometimes you're double spinning it, sometimes you're doing a single spin, you're collecting a very large amount of blood, and you're ending up with getting a very low output or a low volume of a PRP. So clarity of the outcome in the context to quality as well as the quantity of your growth factors was always a challenge. Then quantification was very difficult to do through a PRP. Results were mixed. Some surgeons got excellent results, so they were pretty happy with the procedures. Some were having satisfactory results, and obviously the most biggest problem was post-procedural pain or inflammation, like reactive synovitis, because many unwanted cells used to be a component of your PRP, like RBCs or WBCs, which would not separate that well, and that used to cause the problem or the inflammation, which would cascade the release of growth factors, and patient used to complain of pain, especially in the first 24 hours to 48 hours. The complexity of the procedure, yes, you need at least 1 to 2 people to prepare your PRP. It takes time. And if not done in a proper aseptic environment, the xeno-free environment, if not maintained, sterility is to become an issue. And obviously, you need a good amount of staff to prepare it. Now, when we started working on it on Ossinext or the autologous growth factor concentrate kit, we had three important questions in mind. Our research team, our stem cell biologist, Dr. Vijay Sharma, who's been the brain behind this entire kit, he studied it in depth and also came up with the consequences of that. Three important questions have to be addressed when a patient is being treated with a PRP. how exactly the platelets are getting activated, how many are getting activated, and actually how many growth factors are getting released. So this was a big challenge when it came to doing a PRP. But yes, when we devised the whole thing, we started working on it, and finally we devised a kit which would cause an in vitro release of growth factors that is outside the body, which would help the doctor to inject pure growth factors into the patient and get faster results in a less amount of sitting. So that's where it came in the picture of Ossinext, which is the autologous growth factor concentrate kit, the first kit approved by Government of India through the CDCSO under medical devices class A. It's a very simple kit to prepare. It takes barely 40 minutes and it's very easy for any doctor who learns it once, and his assistant can himself prepare the kit for him. So you need to collect just 4 ml of venous blood, invert it 5 to 6 times after putting it in our vacutainer. The vacutainer consists of a Wokhart proprietary solution, which is like a platelet activator comprising of calcium chloride and dextrose in a ratio which we are using it. The most important thing is after you collect the blood, the tube has to be inverted 5 to 6 times and kept at a standing time of 30 minutes, where the key step is the platelets available in your whole blood will mix with the reacting solution and will start releasing the growth factors. And after those 30 minutes, we centrifuge it at 3,400 RPM for 10 minutes. And there you get the separation with the golden color liquid, which is your growth factors right at the top. And the other blood cell component like RBCs and WBCs go well below, which is separated by a thixotropic gel, which comes right in the center and becomes hardened. So the basic concept was there to, yes, to give you a pure liquid, a pure serum protein to inject so that the advantages of a growth factors compared to a PRP would be established. When I talk about the advantages, yes, this is a non-surgical procedure. There is no platelet loss. A high concentration of growth factors are given to you. Completely acellular, so no risk of pain or inflammation after injecting. Stability is excellent. Even at room temperature, the growth factors can be stable up to 8 hours. It's a safe option, no risk of any contamination, and it's a simple protocol where one single person can easily prepare it. So this is in brief about what Ossinex actually is and how this entire kit got devised and came into existence. So now I would invite my speakers for today, firstly starting with Dr. Subhash Jangid. After the Wokhart Hospital did its initial work, Dr. Jangid is the first person in the country who started using our kits. He had the confidence. He gained the confidence after we met him. We had given him some samples. He started using it. He got good results. And today he's there to talk about his experiences regarding two important indications. One is osteoarthritis of the knee in the early stages. Yes, definitely. And also in tendinopathies like plantar fasciitis, tennis elbow, where Dr. Jangid has been using this product for a very long time with having excellent results. So I would now hand over to Dr. Subhash Jangid, who's the head of the Department of Fortis Hospitals at Gurugram. So over to you, sir, for your experience sharing.
Yeah, thanks, Dr. Salim, and thanks, Neeraj. So, I was not aware that I was the first one to use this in the India. But anyway, so my experience with the orthobiologics is quite long. So I'm using the PRP for last almost 10 years. At that time, no kits were available. So I used to visit my blood bank in charge and told him that they have a machine where they can separate the platelets for me. So from those days, I started using these PRP, and the results were very good because at that time you have to use the 3 injections weekly apart or every 10 days apart, and then the some ready-made kits were available for the PRP, and then one day Salim came and showed the Ossinext, which actually because I was having a good experience with the platelets, so I knew that this is going to work, and this is something which is very quick, very easy to prepare, and the biggest thing was the sterile container. Because when he used to prepare in the blood bank, the sterility was a concern because there is a big machine and they separate out, and then always was a challenge whether it's sterile or not. Sterility, then preparing within the clinic, you can keep the kits readily available for the patient, and the stability on the room in the room temperature. These few things actually clicked, and acellular. Then when I experienced using this, then I realized that the acellularity of the product actually is very, very good because after giving the PRP, some patients used to complain that they have pain for a couple of days or maybe 3, 4 days, sometimes a week as well. Now, after started using GFC, my use of PRP is completely gone. I only exclusively use only GFC. And the advantage that the patients who have significant pain, even when injecting the tissues like the tendons, is minuscule, maybe less than 5%. And I cover them with the paracetamol, 1000 milligram twice a day for 5 days. No other NSAID, because NSAIDs actually deters our use of the growth factors. To share the list of indications, I have a huge list of indications. So because I started using it and then I extended my indications to a lot of things. To begin with, I start from the OA is the main factor here. So OA of the knee. So young arthritis is a big problem for us. We see a lot of patients who are young, like in their 30s, 40s, and they start developing arthritis. They are not able to do their routine activities or do their running, cycling, climbing stairs in the office. Or some people, they have the trauma of the proximal femur or the distal femur, and there they start feeling pain because they're a bit of maybe post-traumatic damage to the cartilage. So these patients, I have a number one indication for them that you are in 30s and 40s, you may be heading towards a knee replacement, but the later you are, better for you. So we want to delay the surgery, and we don't know how long we can delay, but at least delay it as much as possible to take you to the age of 50s or 55 or 60 sometimes. That's number one indication. So stage 1 is stage 2 arthritis. There's a strong indication. Once the deformity starts developing or there is a significant damage to the cartilage, then either you do a focal damage, then you can do a surgical procedure. And after surgery also, suppose we have done a Oates procedure, we have done a cartilage transfer, we have done a chondro filler procedure, we have done a meniscal repair. We are using it them nowadays. The recovery has been phenomenal. And we have now the post-surgery 6 months MRI as well. And it's showing pretty good healing in the meniscus. Now, we are planning to add this to multiligamentous injuries as well, like the ACL-PCL combination or ACL with chondral damage. So we are adding this indication to them as well. Now, in knee, one more thing is there, which is quite common in the younger patients, is the chondromalacia patelli. Significantly disturbing their lifestyle because stair climbing, getting up from sitting position is painful for them. And they have focal damage on the patella. Some people do arthroscopic chondroplasty, but my first indication is to give them injection, lifestyle modification. And we see that after 6 months, and I tell you almost 90% comes back that they have improvement. Few of them, because I practice an area where people are quite vocal and they want to see objectively whether it's improving or not. They got their MRI after 6 months, and we could show that their lesion in the patella has gone significantly down, and they go in the confidence. One more indication in the knee itself, post-COVID, we have got few patients who have got the sponk, and 2 patients I have with them because it's a rare thing. And last 3 years, I have injected them twice. We injected them, they got better. They came back after 1.5 years. We have again started getting pain. Give it right now so that it doesn't progress. So these things, they give you confidence that it works. Now, if I go beyond the knee, because I have a lot of experience other things as well, so I'll start from the top. So shoulder joint, supraspinal tendinosis, very good result. You give one injection, and I tell you one more thing because Dr. Salim knows that I give a different name to this. So I give 2 shots, 1 injection. So less painful, less visit to the doctor, and cheaper as well, because coming to the hospital or the clinic, coming 3 times, injecting 3 times, taking the sample 3 times, so 6 pricks. And cost of injection is that they are giving it 3 times, so you charge 3 times plus 3 kits are used. So we use double the dose, single shot, 1 visit to the clinic or the hospital. So that really works same way. Now, supraspinal tendinosis, and when we repair the rotator cuff, we inject that after 3 weeks so that the healing becomes fast. So probably for the healing from shoulder to elbow, tennis elbow, golfer's elbow, tricep tendon, the olecranon bursitis really works very well. And I've used them for all patients who have like been suffering from the tennis elbow for 1 year, 9 months, tried all kind of physiotherapy, other injections, twice injected with the steroid, and I given them, and they come back with a positive response. Sometimes in these patients who have been like suffering for 8, 9 months, you have to give 2 injections, so total 4 kits. But definitely, surgery is the last option for them, and we can avoid surgery because of that. Coming to the lower limb, Dr. Gandhi has an experience with the AVN. I don't have an experience with the AVN. We use intraocular bursitis. Then knee, we have all discussed. And osteochondritis dissecans of the talus. Despite doing the arthroscopic surgeries for few patients, it doesn't improve that much. So if the defect is significant, we do surgical debridement, chondroplasty, plus GFC, or if it's early stage, we use straight away GFC. For the talus, we have to give 2 injections, so 2 sittings, but 6 weeks apart and double dose. And then all those patients who have the plantar fasciitis, Achilles tendinitis. In Achilles tendinitis, you are worried about if you give 3 injections of steroid, the tendon may rupture. There's no risk of rupture here. And we inject this retrocalcaneal. So anterior to the tendoachilles, just behind the calcaneum. You inject it there, it's less painful, and it gives you very good recovery. Same thing with the plantar fasciitis. Don't inject in the tissue because tissue will expand with the injection and gives too much of pain. Right underneath the fascia, at the bottom of the heel, you give injection, goes freely and recovers very well. Plantar fasciitis, Achilles tendinitis, post ACL, post meniscus, osteochondritis, tennis elbow. Now, whenever we get a case in OPD where we see that this patient probably is not a very good surgical case because Achilles tendinitis is, again, there are a lot of risk involved for the surgery. And where we already used, or someone else has used this steroid, is not recovering. We have used it. That's how we extended our indications. Plantar fasciitis and Achilles tendinitis. Patients are coming because they don't want surgery. They have tried each and everything, not getting relief. That's okay. We have an option. We'll try it. We initially started with a trial only. One patient, second patient, they came back with a very good response. They came with feats. We have not felt so better for so many years, months. That actually gave the confidence. And I, along with my colleague in PGI, did the study for the double dose. And we found that the results are good, and now we promote that we should use a double dose of GFC, single sitting, single shot, economical for the patient, convenient for the doctor, because it's difficult in a city like Gurgaon or Delhi or Bombay. The patient coming to you 3 times in a month and taking 1 hour for the injection to be prepared and injected. So that's how we decided, and I think we have got a very good result. If anyone has a question, I'm ready to answer that. Thank you.
Right. So I think we'll take Neeraj, any questions for Dr. Jangid so far?
Yes, we have some questions from our audience.
Yeah.
So you mentioned that you give it in shoulder for the supraspinatus tendinitis. Do you also give it in frozen shoulder?
No.
Adhesive capsulitis?
So adhesive capsulitis is already an inflammatory process going on. So you cannot release the inflammatory process. This is an actually pro-inflammatory factor, which the inflammation works in such a way that it helps in the relieving the pain and relieving the inflammation. It's a pro-inflammatory along with anti-inflammatory. So if in a frozen shoulder, the inflammatory process going on, that is causing the stiffness. And in shoulder, if you want to give injection, then you have to give rest for 3 days, and then you cannot release the capsule of the shoulder. There's a fibrosis going on after the inflammation. So it doesn't work in that. It's primarily where the tendinitis is happening. So supraspinal tendinitis works really well. Patient is having early stage of the maybe a towards the we call it the articular side partial supraspinal tear. It works really well in them.
Yeah, I was about to ask you about the partial tears.
Yeah, so partial tear is very, very good. It really works.
Yeah, really
And then
works
you
very
start
well.
them with the adductors and internal rotator strengthening exercise so that they work on the shoulder depressors. So the supraspinal is relaxed. It really works very well.
So you said
And
that
my urologist in my hospital, he got a tear. So he showed to his shoulder surgeon, he said operation. So I saw his MRI, so it's just partial tear. Don't worry. If you want to try, we can give an injection. Now he just says, okay, I'm fine, no worries at all. Partial tear is a very good indication. Very good indication. Along with the good physio, because if you go to a physio for a shoulder pain and he's not a good physio, what he will do, he will say start the rotation, up, abduction, and you have to avoid these movements. You have to work on the adductors and internal rotators. So those are the depressors of the shoulder. So that
Yes.
opens up the subacromial space. That works really well.
okay, that's really good to know. So because you're giving it in shoulder and in such a specific indication, do you use a C-arm or a sonography guided, or do you give a blind shot?
Ultrasound guided.
Ultrasound guided. Okay. You also mentioned that you give this injections also in the rotator cuff tear after surgery and meniscus repair after surgery. So my issue is that when I have tried to give it, I feel that they wash out. How do you prevent the washout?
So I told you I give it after 3 weeks.
Acha, not immediately during the surgery.
Not immediately. Not immediately.
Okay.
That's a waste. That's a waste. Sheer waste is nothing else.
When do you start seeing results, and in the interim, how do you take care of the pain for any condition that you give?
So suppose the patient is having an OA of the knee, early stage 1 and 2. So they are not in severe pain. They have difficulty in doing certain exercises. So initial pain, we give the paracetamol for 5 days, morning, evening, or some people they say we took only for 2 days and ice pack for 5 days, 3 times a day. After that, you will start seeing result by the end of 3 to 6 weeks. Till that time, you can cover them with some kind of analgesic if the pain is very severe, or just with the ice packs and some local ointment. There's no need to give regular analgesic for these patients.
Yeah, usually the pain subsides to a great extent within a week's time.
Within a week's time.
And then they can be mobilized much quicker. That is the usual experience.
You were talking, last question from my audience is what you were talking that you give it in the insertional tendinopathy of the tendo Achilles. So where exactly do you give? And don't you have a fear? Because I always have a fear of giving it, putting a needle there that it may rupture because it's already a little weak because of the tendinopathy.
So that's what I said. So that's why I specifically mentioned that for these tendinopathies, you have to give it just so in an anatomical position, it's anterior to the tendo Achilles or just posterior to the calcaneum tuberosity. So there's a good space there. So what people do is suppose this is the back of the ankle, so they give the needle from behind. I give from the side.
Right. Yeah.
So you go from the side, you are bang on there. And it's very easy to go. It's less painful because if you go from the behind, you are piercing the tendon then going in. If you go from the side, it's much easier. Same way for the plantar fasciitis. Go from the side of the heel. So you are just proximal to the plantar fascia and then you inject it there. It's very easy because if you inject in the tendon, it's difficult to inject. It's very, very tough
difficult.
tissue. You cannot inject there. You have to give the tissue the environment for healing. And that environment has to come from the surrounding, not from inside the tendon.
What size of the needle do you use specifically for these two conditions, especially for the retrocalcaneal area and the plantar fascia area?
So I don't use more than 22 or 23 gauge, not less than that. Not a thick needle, not at all.
And same for the knee also.
Same for the knee.
Okay.
You can use 26 also for the knee, but usually because I work in a setup where my team knows how to make it. So they prepare the sample to load the GFC in the syringe. I take 18 gauge And to give the GFC, I take 23 gauge. So that's a standard protocol. No need to change anywhere.
Okay.
If we have you used it along with the viscosupplementation? No. Okay.
Unfortunately, not. People are using it, but
Yeah,
I
there are many
personally
people
feel that
using
it's a. I think we are not using the any of the product as a like as for advantage. If I have to use it, so I will probably use a GFC first, and then after 2 months or 6 weeks, I will use a viscosupplementation if patient wants to use it.
Okay.
But combining both, like it's
Not good.
probably I don't even mix any steroid, no local anesthetic.
Steroid, I'm not talking about. I'm talking
So
viscosupplementation.
no viscosupplementation, no steroid, no local anesthetic, just a pure GFC only.
Yeah.
Right. Thank you, Dr. Jangid, for an excellent review about the product. And now I would invite Dr. Chirag Borana. He is also from the Wogard Hospital, and he was the principal investigator for a study against hyaluronic acid. So I would ask Chirag just to share his experiences and the number of patients he had seen, and he had injected GFC in them vis-a-vis HA. So over to you, Chirag.
Hi, good evening, everyone. Thanks for the opportunity. So my journey with Ossinext started when Dr. Salim approached to me and said, like, let's try this. And if you would be interested in becoming a principal investigator. So Masina Hospital allowed me for this. And at that time, I was already using PRP and I was pretty happy with the results. So, the transition from PRP to Ossinex was not very difficult because I had already seen PRP results and they were promising something better than PRP. That's how my transition happened, and it was very easy for me to accept it. And when we are doing the trial, so basically we had almost 24 to 25 patients in which I had injected. And the protocol was like stage 1, stage 2, and very, very early patients of stage 3. And these patients were injected once a month for 3 consecutive months. And the best part is, since it was a study, we followed them up for almost a year or more than a year now. And the study is almost 2 years old, and we are still following them up. The initial results are very promising, and I'm very happy to say, even after 2 years, more than 70 or 80% of them are still happy with the results and they are still pain-free. So this, gave me a lot of confidence. And now for last 1.5 year, I've started using in my private practice as well with similar results. So that is where the transition happened. And that is how I build up the confidence in this product. Now, HA again, not that the HA results were not good, but it was a blinded study. So patient didn't know what we are giving. But at the end of it, HA patients were little grumbly, not that they were complaining, but definitely Ossinex patients were much happier. Now, I've been using it in my clinical practice, and even I have developed this protocol. And after hearing from Dr. Subhash once, even I give 2 doses at one shot, and I primarily only use it for OA. I have not tried it in any other indications as if now. Only once I tried in a resistance case of tennis elbow, which definitely gave a better result. Patient was 75 to 80% relieved of pain. Now, I have followed him up for almost 3 months now. He's still pain-free. And he's asking for a second shot, but I'm not sure whether it will give much better result after this or not. So now I'm more tempted after Dr. Subhash's talk. I'll give him a second shot as well now. But for OA, yes, it has been a wonderful journey. And definitely my work in Ossinex and OA is definitely going much stronger. And now after listening to you guys, probably I'm a little more confident of giving it in shoulders and tendinopathies also. So apart from that, the study itself, was a very brilliant study. And it was a very, very smooth study. We didn't have any patient who's come back, saying we are in a lot of pain, or that was the best part of the study. We didn't have any challenges. And in that study, again, we had not given anything. We had not mixed steroid. We had not mixed any local anesthesia. And we had not even given paracetamol after the injection. And that was the whole part of the study, not to give anything and just to see the effect of Ossinex. And it was brilliant. So I think in all, this is a wonderful product, and I'm like I'm giving it for last 2 years, so I can definitely vouch for it, especially in OA.
Thanks. Excellent, Dr. Chirag. Yeah, Neeraj, any questions for Dr. Chirag? You're on mute, Neeraj.
You mentioned mainly that you use for OA
Yeah.
of the knee. So what grades do you use? Do you use it even in grade 3 and 4, or you use only in grade
No,
4?
no, no. Grade 1, grade 2, and also in those patients, who are young, who are having pain, the pain is not much relieved with physiotherapy, and then they come to us, sir, we have tried with a local physician, pain is not settling. That's when I advise them. I don't advise them on day one of the first visit. You come with a knee pain for last 5 days, and now I straight up inject you. I tell them if they have tried other treatment, it has not worked, then might as well, rather than going for any bigger treatment, let's try this. And that's where is my indication more, in resistance cases where they're not responding to conventional treatment. Not that I'm giving it for every patient in grade 1 and grade 2. Only those who are still symptomatic, still having pain, still uncomfortable, only then I'm giving. And very, very early grade 3, where joint space narrowing is there, but they're comfortable doing the activity, the range of motion is full, but they are demanding and they want pain relief over there.
So it is recommended earlier that when I started giving it, that to use 3 shots total once every month. But you mentioned that you give 2 shots, means the double dose in one sitting.
First sitting, I give a double dose, and then I call them up after 2 months, and then I decide whether the next single shot is required or not. Like that.
So what happens? You give the second shot when the pain has remained the same, has reduced, or it has increased? At when situation
If if the pain has reduced and it is not completely gone, then when I give the second shot, if the pain is completely gone, I do not give the second shot. If the pain is still there, then I investigate further. I don't give it. I tell them, yes, probably we are missing something. Let's investigate. Let's do an MRI and find out if there is something else which we are missing. And that's how we progress.
Do you use if the patient has effusion of the knee?
No, no, no. I don't use it for the effusion. I let the effusion dry, and if that still they have pain, then.
But sometimes the effusion is so big that you need to aspirate and at least give something
Absolutely.
like
Chirag.
Yeah, but I have no experience in effusion patients as such. And what I've been practicing, I don't even aspirate the effusion. I just give them bed rest, long knee brace, and I allow it to dry. And I think in last 2 or 3 years, I have not aspirated a single knee for effusion. They all dry out with rest.
Besides OA of the knee, any other knee condition where you have given?
Now, off late, last 3 months, I've started, I've given 4 or 5 patients for chondromalacia patella. So before that, I was not very confident of it. I read about it. I learned it from, Salim and Dr. Subhash. And then I built up confidence. And now I started giving for chondromalacia also. That also, if I try conservative treatment not working, then I advise them. So again, my protocols are very, very simple. I don't give it as a first line. I give it for patients who are not settled with the first line. Then when I advise them this.
For chondromalacia patella, do you give it in a specific location?
I give from the lateral in the suprapatellar region.
Okay. And all others you give it through the anterolateral arthroscopy portal?
Same
place?
Same place.
Achha, you don't give it to the anterolateral arthroscopy
No,
portal?
no. I'm not very comfortable with that. In my investigation, I gave it from the lateral only. And I'm more comfortable with that.
What about Dr. Subhash?
So for the chondromalacia patella, I give the suprapatellar pouch. And for all my intraarticular injections of the knee, I think to everyone's surprise, I give transpatellar tendon.
Wow.
That's the short way of in the joint.
Transpatellar tendon. Right.
So that is where you use the thinner needle, that 26 number needle.
23, 26.
26.
Okay.
Transpatellar if you poke the 100 needles in the knee, 99.9% transpatellar is in the joint. If you put it through the portal, it's 90% in.
But doesn't transpatellar cause pain?
And you feel the loss of resistance, then you go in, bang in there. I'm not quoting myself, it's a study which says it's the best.
And there are some papers also which are talking about intraosseous injections in chondromalacia patella, but they are a little painful, definitely yes. But results are very much better compared to what you're giving to the original technique. So there were some papers which I had gone through.
Transosseous is a technique which has been used in the Europe.
Europe,
where
right,
people
sir?
use it. So for that
Right.
you need anesthesia. Then under the C-arm, you target the area from behind and
Absolutely.
just reach the subchondral area and then give injection there.
Perfect.
Now, I have not tried that, but I have read about that paper.
Right.
I think these are the questions from OrthoTV.
Perfect. Thanks. Thanks. Now we go to the third indication, the important one. Dr. Rajesh Gandhi, he doesn't need an introduction. Sir has been one of the most vital persons on Ortho TV and also for me. He was the first one to give us an opportunity at Viroc 2022 to introduce the product there, where we had launched with Dr. Subhash Jangid as our speaker. So thank you, sir, for always supporting us and having the faith in this product. And today, sir, you are here to talk about your experiences in AVN stage 2, where you have used along with the core decompression. And the question when I introduce this to the doctors, they always ask me, how do you inject it, whether the backflow happens or not? How do you overcome these challenges? Because in PRP, this has been a very common problem. So how does
Yes.
your protocols you follow, and how can this be prevented by using Ossinext? So over to you, sir, for your experience.
Thank you. Thank you, Salim Bhai, for wonderful introduction. Uh, let's come to the point. Now, first and foremost, I have used Ossinex in variety of conditions as everybody has been using, mainly for the osteoarthritis of the knee. Second one is for the tendinopathies, mainly in the shoulder and tennis elbow. I have not had experience in a retrocalcaneal bursitis. I'm always fearful. I always fear that I might just rupture. And I've seen one rupture in my life, and I'm
Yeah.
genuinely fearful and I'm scared. So, no steroids in that region, no injectables in that region. I don't want to be party to be blamed that, oh, you touched it and it collapsed. I mean, it tore. So that's my perception, and that's the way I look at it. So AVN, when Salim Bhai told me that requested that can we conduct a trial on this? Can we conduct some investigations on this? I readily jumped into it. My association with AVN goes back to my college days. It was my thesis topic. So that was the time we had a very meager things available. Hardly anything. MRI was not there. Whatever decisions were done only on an X-ray. And Evart's book at that time had given Figures classification for AVN. So it was a very new classification. The hereditary term was raised after I passed out. So the thing is that the hereditary term was also not being raised. So that's just small historical background. So that the facilities which were available were meager. The treatment modalities were meager. I must share that we have done umpteenth number of McMurray's osteotomies for the AVN. My boss, Dr. J.C. Tarapurwala, at that point of time was England returned, so he was very fond of McMurray's osteotomy. And believe me, we were not even fixing that. We were not even fixing that. So I still wonder today if somebody tells me do any osteotomy without fixing it, I'm scared and I'm worried about it. Some individuals we have done spicas, some individuals we have done them just like that, and they've done well. And fortunately, they did well. They used to get a little coxa magna. That is a little. So now, coxa magna, why am I mentioning this? We have seen any osteotomy or any decompression works. So we were doing a core decompression. We had done at that time the fibular insertions. Now, fibular insertions not only was difficult, but it was troublesome because that time we didn't have C-arm. So where to put a strut? Today we have a C-arm, so we know where there is a head at risk, support that, straight axis support, etc., etc. Those theories are there. So we did not know where to put in. And some of the people used to think that fibula will get absorbed. So that's how the concept of the decompression and doing something to regenerate the bone started coming in. So that time I had in couple of cases after the core decompression, I put in a bone graft, shoved it in. What worked, we do not know, but something worked. So that was the reason. That is when Dr. Salim Bhai told me, I readily jumped into it and I told I will do it. I have no hesitation in doing it. Now, what am I doing? I usually take about 6 mm size drill, locate first initially with a small K wire where exactly I am going to go. I like to go where there is if there are cysts, I would like to go into the cyst because there is a hollow area and I can inject the amount over there and it will be possibly of some help. So I locate them and go with the drill. Till then, when I'm withdrawing the drill, what I do is that before making a drill, I usually like to get a small piece of bone out from outer cortex, and that piece I acts as a plug. In the initial couple of cases, what I had done was I used the G bone, what was available readily. I used that as a plug. Very poor way of using it. The bone, if I have done a small osteotomy outside and taken out the small bone piece, that acts very well and that I can utilize. So I use the hollow mill to create that from outer cortex, and that hollow mill, the same plug fits in well over there. So it gives me a feeling that okay, whatever we have inserted, that remained inside, and I keep the drill on, almost remove it. Final part is not removed. I inject and then remove it and then put it in plug. So that is the way I do it. That is why I'm so. Now, what is the observation which I have done? I have not done many cases. We are still, a lot of studies are required, a lot of cases are required. We are working on it, and very shortly we will have a large series, large enough series to be presented. Now, what does it do? Our experience has been extremely good. Reduction in the pain is seen in first few days. Now, that first few days varies from 1 week to 3 weeks. Their requirement for the painkillers have gone down, analgesics have gone down completely. Then functionalities improves. Some of them come with a severe stiffness, like they are not able to sit cross-legged, they are not able to, they have some amount of fixed flexion deformities, etc. Not all of them, some of them I'm talking about. So because they have a lot of response, body has responded unfavorably to the avascular status of the head of the femur. So there they have improved range of motion movements. So we have seen that the range of movements have also improved. And third and last, most important, some of them I have done few years back. So they have not come for the surgery, other surgery, or they have not come for the other treatments. I mean, they have come follow up, but they are doing quite well. So my inference, I would say, I would not say conclusion. My inference is that it possibly delays the surgical procedure or possibly delays the THR or etc. So now there is an argument put forward when I was discussing with my other colleagues. First thing they asked me, is it the decompression which has worked or this? People are, do you do decompression? Quite a few of them don't do decompression also. They wait for it to get worse and then do the TKR, THR. So I asked him, and he was the one of the guys who does THR only. He doesn't do the decompression. I told you don't do decompression. You wait. I do decompression on a regular basis because that was my thesis, and that's what I learned that is going to help them out. So when I'm doing a decompression, I'm injecting something which will possibly help them, and it doesn't cost much, and it is adding to the recovery part. It is giving relief from the pain. It is improving the mobility and possibly delays the surgery. Now, there are cases, there is a natural history of AVN that some of them do improve completely and they get a remodeling of the whole, head of the femur. So, this particular injections help them recover a little quicker and remodeling takes place. So, radiologically also they have improved. Physically, they have improved in terms of the movement wise, pain wise, they have improved. So one can infer. I'm using the word inference. I'm not using the word conclusion for the simple reason for concluding something, you need a larger database, which we do not have at present. So that is how it works. And decompression definitely, to an extent, helps. That is what I am convinced about. A lot of people like Dr. Agarwala has done a decent amount of research, and he does not give zoledronic. He just gives zoledronic acid, nothing else, nothing else. And his dosage is also, there is a specific regime he follows along with calcium, vitamin D3. I guess uh, all of us would do the same thing. Everything will be given, but this is a procedure which possibly hastens the recovery and gives better results. So, Ossinext is a relatively new treatment for the avascular necrosis, and it is not something approved for the treatment of the AVN. So it will take a while before we get the long-term results, etc. And more number of people start using it. So that will have a little more database, and then we can come up with a concluding something. Right now we are inferring, and there is a slightly personal bias also involved. Because I've done it, so अरे यार अच्छा ही होगा, something of that sort. If patient has done well, I'm being very honest about this because I don't want to give a wrong impression to somebody. But it is helping in terms of, as I mentioned about the pain relief and movements improved, and nobody has had a repeat surgery immediately, or they have not come complaining, कुछ करो यार दर्द हो रहा है अभी, और दवाई हलोज खाना पड़ता है, something of that sort. So that is, my inference is clear cut that it is helping in some way. So let us continue. That is what is my inference. And like, it is not suitable for all types of AVNs. That has to be understood. Like as usual, uh, beyond certain limit, if there is a head at risk, if the well, it's a small area of head at risk, you can try. But if it's a larger, if there is a cartilage shell only, and the larger area has become avascular and larger area is about to collapse, sort of grade 3 or grade 4, if you can, then you don't do them, then it is not going to help them also. Nothing helps them because whatever helps them is a wait and watch and then do the definitive surgical procedure, something of that sort. So effectiveness of Ossinext depends on the level, I mean the grade of involvement of the head and how much head is remaining. That is equally important because if the large amount of head is affected, then there is nothing to regenerate. Because we are waiting for the normal tissue to regenerate and stimulate them to regenerate. So that is what is my perception. This is what I have seen. And I think I've done a lot of monologue here.
Sir, may I have a question?
Please, sir. Please.
Sir, you take a small core of 6mm hollow mill.
Yeah.
And then how many drills do you do inside?
I do one drill only because when I'm using the Ossinext, I'm using one drill. Formally, I should do 4.5 mm ka 3 drills. Initially, in my thesis stage, we used to have 10mm drill.
10mm.
Fearful because patient walk on a second day. So the chances of fractures increases. So I am fearful of that. So now I use 4.5mm ka 3 drills, 3 drills. And there I target all the cysts, if at all there are more than one cyst. And we try to decompress. When I'm using the Ossinext, I use 6.5mm drill, 6 to 6.5mm drill. Arthroscopy drills I use, long ones. And because it is a big at the top and other side is narrow, so what I get it right till there and then I put in a plug. So it is not difficult to, no doubt, some amount may be spilling out, but it is. And what I do, another thing is, I tell my, I usually do it on a flexure table. So what happens is I tell them to internally rotate. When they internally rotate, because it is anti-gravity ho jata hai. While giving, I am putting it in a neutral position. And when internally rotation hota hai, so this is the trick which I use, So initially I was using only that. Still some spillage would take place and how many minutes you're going to keep it over there. So then I started using chalo apna dimag laga, kuch to karo karke. That is how I started. Yeah.
So how I do is that I use an 8mm core and we take 2 cores.
Okay.
Long ones.
Okay.
Like a cylinder and then reach to the area of the AVN. Then I completely curate out that area.
Yeah.
And
I forgot to mention, I do curate. Sorry, sir. I forgot to mention. Yes.
And these 2 cores, I soak in the GFC and then put it in.
Oh, wow.
Right in the sun.
I have not done that. I'll do that next time.
So that's what we are doing. So because it's very new. So
okay.
Maybe
maybe
you can also start doing it, then we can combine our data. And
it's an evolving thing. It is an evolving thing. I think with the more number of cases, we will be able to come to some inference or conclusion for but it will take a while. It will take a while because very long-term follow-up, few years of follow-up is also required. Then radiological evidence is required, and well, possibly the MR evidence also for regeneration. So let's hope that we come to in coming years we can come out with some concluding evidences.
Sir, one question.
Please.
So how many ml of GFT do you give in AVN?
Well, usually we collect 10 ml. So जो भी बचता है, about 6 mm comes to us. That's 6 ml.
One kit. Around about 4 to 6 ml is what is being
4 to 6
one
ml.
Kit, one kit is sufficient for a femoral.
One kit is sufficient.
You can't inject more.
Bone is unyielding. See, the difference between the knee and AVN is massive. Bone is unyielding. Whereas the knee has some space.
Hmm.
You would have removed the effusions of 100 cc also many a times.
Right.
But here it is unyielding space. It doesn't yield at all. And whatever you put extra, तो बाहर ही आ जाएगा. I have used to and suffered.
Okay, so one is
Patient has
Actually,
suffered.
in femoral head, you can't put more than 3 to 5 ml.
Yeah. It
It's
is
difficult.
impossible to. It is impossible to
Impossible.
put it. Impossible.
So some questions now from our
Please.
audience. When do you start seeing pain relief in the AVN?
Well, as early as 1 week. As early as 1 week. It's quite variable. My perception is very clear. In a first week, I do not consider pain relief as a pain relief because I have given some painkillers because we have operated. Though minimally invasive, today with the Shyam, we can just take a small nick and put in I have a long sleeves. So I put that. But nowadays, I have to open up a little bit. For the simple reason, I have to take that small area of a cortical bone. So as to put in as a plug. So then my incision has started increasing about 1.5 to 2 inches. So when we have done that, we have removed the piece of the bone. So they do get a relief from the AVN, but they get a post-operative pain. So we need to manage that post-operative pain for 3-4 days. So usually the results start showing in it is varying from 7 days to 10 days, usually.
Okay, so you give NSAIDs in the first few days.
Yes, I do give.
Dr. Chirag, I did not ask you this question. Do you give NSAIDs post-injection?
No, only paracetamol.
Okay. What about alendronate or zoledronic acid? Do you give with the procedure or have the patient already taken before they come to you?
I give it to everybody.
Which one? Alendronate or zoledronic
I
acid?
give zoledronic acid. The reason is that I am sure that this particular drug has gone in the required dosage. The reason, most important reason, the compliance. Oral medication compliance is extremely poor. And when they are told that you have to take it early in the morning, first thing in the morning,
Absolutely.
you have to sit upright, you don't have to lie down, you have to take it on an empty stomach. See, they consider this as a 4 instructions. They don't consider it as a 1 instruction. They go, "इतना ज़्यादा क्या कर रहे हैं?" You something of that sort. So there is a lot of reluctance. First and foremost, they are unhappy with their problem. They don't understand what AVN is. By the time they understand, they are already stage 2, stage 3. Many people come at a stage 3 because a little pain is being ignored. And umpteenth number of times we have seen they are investigated for a backache because they do have a gluteal pain. So they are investigated for backache, back exercises are being done. It must have happened to all of us. Back exercises are done, back MRIs are done. Incidentally, one patient came to me because MRI guy called me up. यार किसी ने एक्सरे बोला था but MRI बोला था. I saw the hip is involved. Would you like to see him? Because he knew that I have done few decompressions and I'm working on a non-major THR type surgeries. So he called me up, and that is how I came to know that okay, we can miss. It's human to miss.
So, my question was maybe not clear. Do you give zoledronic acid immediately after the procedure or before the procedure during the same admission?
Yeah, during the same admission.
After the
Because
procedure.
that's easier. They have to come for a couple of hours. So it's easier to do.
After the procedure.
After the procedure.
Issue is that it causes fever.
In 16% of the documented patients,
Yeah.
1 in 6. So we are already giving them anti-inflammatories and possibly analgesics. So part of that is paracetamol. So, well, it is a preferred drug. 1 gram they say, so it doesn't cause much problems. So, and as I mentioned, I already give for 4 to 7 days. So that if at all that effect of a zoledronic acid is there, it is usually seen in 48 to 72 hours maximum. So
And
that is also taken
you
care
have
of.
done limited number of cases. So up till now, how many cases have you successfully done where you have got some results?
Well, I've done about 7 cases, and practically all of them have got a good relief from the discomfort and pain. They have got an increased mobility. Long-term results are still long way.
Right.
How long
So
do you keep them non-weight bearing?
I don't keep them non-weight bearing at all.
Okay.
Day 1 is they are lying down because most of the surgeries are done with spinal anesthesia. So day 1 they are lying down. Second day onwards they go to the toilet and whatever is comfortable is there. I don't advise them to go to the workplace because many times they should not trip and have problems.
Okay. I think, Salim, that's all from our
Yeah.
OrthoTV side.
Right. Thanks. So
I think
just to, yeah,
I can now
right.
conclude
Yeah,
this
sure.
in a great webinar or a
Yeah.
podcast.
So just one thing I was just want to enlighten all our panelists that we have started a trial on AVN now at few centers, and I think Dr. Gandhi is also a part of it now. And definitely I'll be meeting Dr. Subhash regarding that as well, because this is one of the indications where data has to be generated as quick as possible. And the
Yeah.
most important part is when we talk about NSAIDs with GFC, to be frank, it's absolutely safe to give any NSAID with GFC, because finally a growth factor, if you analyze it, there is no platelets at all. So that platelet interference or aggregation is never an issue. So I'm practically giving a selective COX-2 inhibitors to all my patients who are being given GFC. So that is one of the advantages what we have over a PRP. So this is just to enlighten the panel about the entire thing. So I thank all my panelists, Dr. Jangid, Dr. Borana, Dr. Gandhi sir, Dr. Neeraj for an excellent discussion we had today on all the various indications, and looking forward to have many more in the future and generating more and more data. So thank you, Neeraj, and thank you to all the panelists for this excellent podcast. Over to you, Neeraj.
Thank you very much.
It was excellent. We all got some knowledge from each other.
Yeah.
Oh, yeah. Definitely.
So-
Sharing of the knowledge is always helpful
It's important.
and it makes us better doctors. I always believe, and good. Thank you.
Thank you, sir.
Thank you.
Thanks for
Thank you.
sharing
Thank
your
you.
Thank you, everyone.
experience.
Thank you.
Thank you. Bye.
Thank
See
you.
you.
Stop.
Thank you. Bye.
Yeah, sure. Thank you.